The reason why people are not well educated on how to talk to patients today is because of all that occurred. And then the myth has continued, which is why I appreciate you doing these so we can try to help get the real message out.
Absolutely. Welcome back, everyone, to VNEW Health Podcast, dedicated to advancing women's health through expert insights and real conversations. Today, we continue our deep dive into menopause with Dr. Jarnagin, part 3 of our series. He is a highly respected urogynecologist with over 3 decades of experience, and we are entering our third podcast talking about this particular topic, and we feel like there is still so much more to talk about. Now, menopause is a phase that every woman's going to experience, yet it remains one of the most misunderstood and debated topics in healthcare. One of the most researched menopause-related questions is hormone therapy right for me? So I looked that up, and I wanted to see, what am I going to find? And the interesting thing is that there are over 74,000 searches each month where women type in estrogen replacement therapy. So very, very well, it's such a topic that we are diving into it. And at the same time, not a lot of direct answers, which is what we're going to try to give you this and every podcast. So women across the globe, they're always looking for answers. They're always seeking clarity on the risk benefits and, of course, whether hormone therapy is right for them. We're going to dive into some of those topics tonight, and we're going to talk about those shifts in menopause care over the years and what happened with one of the particular clinical trials, the role of both hormonal and non-hormonal therapy, and then how healthcare providers can better support women through this transition. So we are very, very proud to have Dr. Jarnagin back in the studio and being able to share his insights on what that looks like. Dr. Jarnagin, welcome to the program.
Well, thank you for having me. I always appreciate being with you.
So we were talking back in the green room before we jumped on, and one of the things that was interesting was, is there a particular studies or area that if women want to dive into some more research on their own instead of trying to sift through, over 3,000 clinicals just on the topic of menopause and hormone replacement, and I'm sure it's in excess of 10,000 if you really expand the search. Where would you point someone in that direction to say, hey, maybe you want to check out this particular physician, author, scientist? How would we best do that?
So I think there's a couple of things to think about. And as you were talking, I reflected on the hormones traditionally were commercialized, commercial prepared by pharma and delivered, and they were in set dosing, and it was progesterone and or synthetic progesterone, depending on the case. And many studies bore out of that. There was an author way back when in the 80s and 90s, PhD guy who did a lot of the effects of estrogen on the brain, the skin, the bone, the jaw, etc. His name is Erickson. They're old studies, but they're still very relevant. And part of the interesting thing is there's now some newer studies looking at the effects of hormones on brain, bone, jaw, skin, etc. And they corroborate everything that Erickson did way back in the 80s and 90s. And it shows that the communications, the neurons within the brain branch like a very well healthy tree. in women who are on estrogen, and they kind of tend to wither and become less branched in women who do not um, do estrogen. And a recent study just within the last, I read it just within the last week, was on estrogen therapy and the reduction of uh, dementia and cognitive decline. And it also talked about, which is very important for our audience, is the menopausal symptoms. So if you're going through menopausal symptoms and you're not getting treated for that, that is going to affect you long term cognitively based on the studies that have recently come out, as well as the studies that go back to Erickson. But so it is important that for those of us who are out there listening who are having menopausal symptoms, it's important that you realize that what you choose to do or not do today will affect you cognitively, heart wise, skin wise, bone wise, down the road.
So it doesn't matter what you spend at your dermatologist,
Yeah,
different injections, different fillers, different products that you are doing. If you're not being balanced with your hormones, none of that really matters.
that's
You gotta
exactly right.
you gotta work from the inside out.
That's exactly right. That's exactly right. And so that all came, and then there was a guy named Joel Hargrove who, fortunately for me, was right down the road from me, and he and I were both at Vanderbilt together for quite a while, and he was the forefather of bioidentical hormones, or one of the forefathers. There were a few, but he was one of the forefathers, and he did studies, and he is largely responsible for kind of where those norms ought to be. So when I'm utilizing bioidentical hormones and I'm giving women hormones and I'm testing them to see where their levels are, he's the one that kind of said, all right, women feel better when they're in this range. So that's where we're going to try to get them. Um, and um, and so he co-authored books, he wrote articles. They're going to be old. Bless his soul, he's passed away, but he was the forefather and one of the most brilliant men I knew as it related to hormones and pathways, et cetera, et cetera. So
What year was that, Dr. Jarnagin? That he was
yeah, so that would have been early 2000s.
okay. And then when did the uh, release of the WHO uh, trial and what year was that?
2002.
Right, so just right after that. So there was right in that mix of what he was doing and then what was released. Because you talk about, you say, "Hey, that's old," but, really it's still very, very relevant, uh, because we still don't have all of the answers, but we're it's almost like we're going back to, what was found, um prior to in and around 2000. But there's also this whole gap of not educating. Maybe you can explain that and why that was a little bit more in depth, because we kind of touched on it on one of the previous shows. But I think it's very important because when women go, hey, you know my gynecologist has delivered my kids. He's has known me forever. Why wouldn't he bring this up to me?
So to clarify, Dr. Hargrove was doing his bioidentical hormone work in the 90s. He and I worked together in the late 90s, early 2000s. But all of his work and his research was done prior to that. But so to your point, this is a generational issue, right? So this was 2002. That's 23 years ago now that study came out, give or take, and that made a large impact. And it's one of the things that probably put healthcare for women backwards by a lot of years. And but what happened is that was so publicized and so ran with in the news media, etc., that it permeated all the educational systems. And so, if you were a resident or medical student or PA student or nurse practitioner student back as that study came out, then you were influenced heavily by that study as you were getting through your educational process and then going out and going into the private sector and taking care of patients. And then if you were in there and then you went on to be an academic professor, you were teaching what you learned from that study. And so without really deep diving into the study of Erickson and the study of Hargrove, you put all your eggs in a basket of this WHI study, and you learned and taught and or practiced related to that study. And I may have mentioned it before, but it's worth mentioning again. I lectured on this when the WHI first came out, and you could tell that there were serious concerns about the study. And as I lectured, I went in front of a lot of people and a lot of associations, and I always started my conversation by asking two distinct questions. The first question was, who has changed their prescribing habits based on the WHI study? And no matter who I was talking to,
How many people raise their hand?
95%, 95%. It didn't matter whether I was talking to physicians, PAs, nurse practitioners, it didn't matter. 95% across the board changed their prescribing habits based on the WHI. And then I asked the second question, how many actually read the study? And it was consistently 5%.
Yeah, those are the ones that didn't raise their hand.
So the 5% that read the study saw the same concerns I saw. Everybody else got there from the publicity of that study. And so that's where the flaw came from. It came from the publicity of the study and some inaccurate data. And then that data has all been subject to review, and subset analysis has shown that, okay, well, there may be concerns about this small little fragment here, this little box of people, but not for the vast majority of people. And so the ones that were having trouble in the study were people who were naive to hormones in their 80s and started hormones.
Which you even talked about on the previous show is like, hey, that's a risk factor. You haven't had hormones for over 10 years, then we gotta go really low and really slow and be aware and understand what those risk factors are.
And so those that started at the right time did not have those same risk factors. And then the other risk factor was a synthetic hormone, not the bioidenticals, and not even some of the other commercialized progesterones, but a particular synthetic progesterone, which is no longer really being used. And but that information is not publicized very well. It's not out there. It didn't make the news media. It didn't make the television. It didn't make any of those publicized areas. The USA Today did not print all the good news.
That's right.
Um,
That doesn't sell newspapers. Well, they're not around anymore.
so
Anyway,
the myth has continued throughout all these years, and the reason why people are not uh, well educated on how to talk to patients today is because of all that occurred, and then the myth has continued, which is why I appreciate you doing these so we can try to help get the real message out.
absolutely, absolutely, and it's it's so beneficial, for people want to weigh in on the conversation. You know, like the channel, like VNEW Health, subscribe. It helps us. It helps us continue these podcasts each and every week so that we can continue to bring great information. And if you find this information beneficial, also love that you can share it with one of your colleagues or one of your family members. So One of the things that you touched on, and I'm curious about, is we've seen this bioidentical, but then referencing the synthetic. What's really changed from a technology standpoint from what is being offered to women that maybe wasn't being offered to them, 20 years ago?
Yeah, so that was Dr. Hargrove's, achievements of going, okay, well, he felt like, and the more I see and the more I have been around, I think it was absolutely spot on, is that women are not a one size fits all. And so you don't necessarily fit to a one dose or other dose, and women's absorption rate is different, and we've seen that in the bioidenticals when we're checking hormones, and so the value of the bioidenticals is I can check lab values and I can go, okay, here's where we are. Whereas some of the other formulations you can't really check; you're kind of guessing based on how patients feel. Well, some women are going to be way up here, others are going to be way down here with their absorption, and if you can't check that, then you don't really know where they are. And I think, and he thought, and I think as well, that that's probably where the concerns come from in women and potential disease, is because you may be taking it and you may be thinking you're okay, but you're really way up here. Your body's seeing way more hormone than it really should be seeing at that point in time. Because the realities are, women, they start producing hormones depending on their genetics and nutrition around 12, give or take. So they end about 50. So that's 38 years of hormones. Up until then, they haven't had any trouble. So why all of a sudden does that same hormone that you've been doing naturally for 38 years suddenly become evil in year 40, 41, 42, right? It it doesn't make any sense, because it's this same chemical hormone, and so that I think that's one of the biggest things.
So do you see synthetics being utilized out there still? What do you see being prescribed, or how is that?
So let's be clear on terminology. Bioidenticals are made in a lab. So technically speaking, they are synthetic. They just happen to be made to be bioidentical or exactly like what your body used to make.
And so those are different ratios because it was, before it was in a tablet. Now how do you find yourself dosing for these ladies? Of course, different ones. But what's your protocol look like?
I personally start out with hormone drops. Like Dr. Hargrove used to put it in Jergens lotion and he would rub it on. And then he goes, I don't know why we were making women bathe in Jergens lotion when you can just do it in a little bottle and a little drop. So from that point on, we went to drops, and it's just one, two, three, four, however many drops. And then you check labs to see where they are, and that gives you your estrogen, progesterone, testosterone all in one drop. And then you check hormones. And we know through a lot of studies dating way back to the 80s, 90s, and the most recent, that uh, percutaneous, i.e., non-oral, tends to not affect in an adverse way lipid profiles, et cetera, which can be concerns to certain women. And so we completely bypass all that by going cutaneous and putting it on the arm or thigh. And then if women don't absorb for whatever reason, we utilize what's called troches, which goes inside the lip and then it dissolves.
Under the tongue, inside the lip, right? Cough, like it's like a little cough drop.
And yeah, yeah, and women almost universally absorb that. It's amazing how well that absorbs. And then beyond that are the pellet technology, where people will come in every 3 months and they'll get an injection with a little pellet that goes underneath the skin and it delivers hormones. Now, it it gets absorbed typically very well too, but there's some issues with that women need to understand. Once it goes in, you can't go pull it out. So if you absorb that a lot way too well and you have side effects related to too much hormone, there's nothing we can do about it until it wears off.
till wears off, and we're gonna adjust your dose next quarter.
Exactly. The other thing is you tend to peak and then slide, which is not exactly, a steady state. Um, and that's why I prefer the drops or the troches because you can once you get a woman here, then they're here every day,
Sure.
and they don't up and down.
But it's more of a compliance issue,
Yeah,
right? People
yeah.
people forget, or they're not, no longer do it every day, and they find that it's just more convenient. So even though it's not perfect, it's better than not having it all.
Oh yeah, yeah, absolutely. And then of course there's the traditional pharma where it can be a pill or a patch, and there's nothing wrong with those. There's nothing wrong with those. You got to just know what you're getting. The pills and the patches are only going to give you either estrogen only or estrogen progesterone. None of the commercially prepared hormones offer testosterone along with their estrogen and or progesterone.
So why is testosterone so important for women that are going through this phase of menopause?
The short answer is their body used to make it, so we're giving it back to them, right? We're giving them what their body made. Now they didn't make as much testosterone as their male counterpart, but they made a little bit of hormone testosterone throughout those 38 years that we talked about. As far as what does it do for you? Well, it's synergistic with estrogen as far as bone health. So it's good for bones. It's synergistic when it comes to vaginal tissue health. So it's good for that. It can be synergistic from a skin point of view. And then, of course, it can offer benefit as it relates to libido, sexual desire, and that sort of thing. And so it is a complement component of the hormone balance that we try to achieve.
How do you look at progesterone, estrogen, in those areas and those levels? What's important to recognize if someone's looking at their labs?
Great question. Great question. And I will talk about a case that I just had. So I was talking to her. We did her labs. Her labs all technically fell into a normal range. However, her estrogen was kind of on the top end of normal, and her testosterone and progesterone were on the bottom end of normal. And she was describing that while she her libido was okay, it still wasn't where she wanted it, and she wasn't sleeping well. Progesterone will help women sleep if it's in a good spot, lab wise. And there were some symptoms that I've forgotten related to maybe a little bit more estrogen than she should. And so I listened to what her symptoms were, and I realized that while everything fell into a normal range, they were not balanced. And so the goal was is we so we're adjusting those, and so we're increasing her progesterone testosterone concentration related to her estrogen, and therefore when we give it, it'll be more balanced, and the goal will be is that she will have good energy, sleep well, and feel more, back to her old self.
No, the great way to summarize that, and I think it's important for women to realize that you get your labs back. It's just a range, right? It's a high range, a low range, and you're right there in the middle. Now you can lean, top or bottom, like Dr. Jarnagin said. It doesn't mean that you're optimal for you, and I think that's so important, having that conversation with your physician and still describing how you're feeling. So now he's able to listen and make adjustments. And hopefully next time she comes back to see you, then she'll be in a better spot. So
Yeah.
what do you find to be your program to you know you get them set up on a initial regimen, and then you start walking them out, 3 months, is it 6 weeks, is it 2 months, how does that work in your practice?
Yeah, so it generally takes about 6 weeks, give or take, for hormones to balance out. So, we'll do labs at 6 weeks, we'll see where they are, we'll make some fine-tuning adjustments, and then we'll kinda recheck it. Once we get everything kinda balanced out, then really and truly, minus a change of some kind, there once a year is probably plenty, once twice a year at the most. But I think getting back to something that we talked about, that I'd like to emphasize is it's important to get with providers who understand the nuances of this, just like I was describing. There's you know, you don't want to get a phone call from the office going, well, all the labs are normal. Have a good day.
That's right.
Right.
From the 23-year-old at the desk.
And the lady, puts hangs up the phone going, but I still don't, I feel better than I did,
Right,
but I still don't feel as good as I think I can.
right.
And then they just kind of get left. So you want to make sure that you're with somebody who understands the nuances. And you're absolutely right. A lab value is one spot on a graft, period. So it's not taking into account what it was the day before or the day after. It is just that one day. So you want to take that number and you want to synthesize that with what the patient's feeling, seeing, and telling you. And you got to find somebody who can do that for you and help you through this period of time.
Yeah, because to your point, once you get there, then if there's isn't anything that's, not life changing, then you should be pretty well on a good pathway, of feeling better, and, you know, cardioprotective, better skin, better sleep. Everybody needs more sleep. Better sleep pushes you into then having a being more productive, having being in a better mood. So all these things are compounding that when you take away your hormones, it just starts to tumble.
Everybody puts testosterone with libido, kind of as the connection, and to some degree that's accurate. But in another way, to your point, it's all pertinent because they may have a normal testosterone and they may be optimized in that, but if their progesterone is low and they're not sleeping well, we all know that lack of sleep reduces libido, right? And so it's important to have the balance so that you get you get the sleep right, you get it all done as a package.
Well, it's kind of like if you uh those Bosu balls at the gym, right? It's a flat surface, it's a ball underneath, and for balance, you jump on it, and women know about this because they'll probably have taken classes with it. This is really how the hormones behave, and you've got this balance where you're going, okay, if I'm too heavy on one side, I'm like this, and I can't do my exercises. I'm leaning forward, I'm not comfortable, or I can fall off of it, even though all three are on. So that's a way to think about what Dr. Jarnagin is laying out for everyone, is that you need all three components so that you have a really nice balance. And when you do that, when you do the Bosu ball and you're all balanced, the exercise is easy, right? You
Yeah.
just like,
Well,
yeah, it's
and
easy.
that's a great analogy, and I think, if you're taking that analogy further, when you walk into the gym after doing it for a while, you know your balance is better, but it's not as good as it can be. And that's kind of where these women are at times where, you start the hormones and they go, "Yeah, I feel better, but I'm not quite as balanced on that ball as I think I can be."
Well, one of the other topics that always comes up: hormone replacement therapy, breast cancer survivor. Okay. What do those women do in those scenarios? Besides, hey, tough it out. You survived cancer, but you're gonna feel miserable for the next 30 years. How do you treat women in that scenario?
Yeah. So, first of all, almost universally, local vaginal estrogen, so treating the vagina, is been deemed safe in pretty much every woman. Now, the
What if you
oncology.
don't like that? What if you're going, I don't want to do that every day.
Yeah, yeah, yeah. But to your, what can you do? I mean, I have seen women who very young breast cancer survivors, and they are sexual invalids because their tissues have thinned and dried, and and it hurts and
Painful.
bleed,
Yeah.
and so you gotta the local estrogen is safe, and so many women are scared because it still has the word estrogen in it, but it is safe for almost every woman. Now, I tell every woman that I see with breast cancer, talk to your oncologist first. Do not do anything without his permission.
What if your oncologist read the WHI study and that's what they were taught, and now they go, no.
And that's a risk. That's a risk. But I think it's important that you don't get crossways with the oncologist, because some women are going to have a complication of their breast cancer. And I mean, I tell women all the time, I go, you may get, the women who don't have breast cancer, I go, you may get breast cancer, but I don't think it's going to be because of the hormones. It'll be because of some other factor. And women can have recurrences, but I don't think it won't be because of local vaginal estrogen. And you can do creams. There's inserts that you can put in that actually have estrogen and testosterone. It's actually a pro hormone that gets converted when it gets put into the vagina, and only the vagina has the enzymes to change it and convert it, so it stays within the vagina. So it's a great treatment to treat the vagina locally. And then, of course, there's lasers that unfortunately are not covered by insurance, but they're designed to treat the tissue and change the histology of the tissue to make that tissue healthier. And it's much like every woman knows about getting laser or radio frequency to their face to make their face look younger. It resets the clock, right? And so, if you're X age, you do the treatment and you go back a few years, and then it starts to, it'll start aging again because that's what it does. But they have lasers and radio frequency energies that are specifically designed for the vagina as well. And so these are all great tools to utilize so that women can continue to be sexually active with their partner, and it still have meaning for them as well as their partner without pain. So that's the biggest thing to impart. The other thing though is every breast cancer patient is going to be different. Was it estrogen uh, receptor positive? Was it progesterone receptor positive? Was it estrogen and progesterone receptor positive? Is it recent, or has she been 10, 15, 20 years out? Was it localized? Had it grown outside the breast? I mean, there's all these variables that you look at before you go, sure, we can do systemic hormones or not. So you have to look at all of that.
So what about, would you say that then you would, for those ladies, would you do a combination of maybe some testosterone cream that they just rub on, as well as say the estrogen
Yeah.
from the vaginal?
You certainly could, and that would also help with some of the bone issues as well. And so I think those are all reasonable things, but understanding where they are in their cancer journey,
Sure.
can is very helpful in making that. And the other thing to keep in mind, and nobody is going to do a study of giving systemic hormones to breast cancer survivors. Um, but
It's like there's no data on something, a drug with pregnant women, right? It's not happening.
exactly. But to your point, and that's where I was going with this. So, not surprisingly, there are young women who have had breast cancer. They're survivors, and they've gotten pregnant. And everybody knows that when you're pregnant, you have hormones that are sky high, right? They have followed those women, and they have shown that there is no real change in survivorship or recurrence risk in that in whether you got pregnant or you didn't get pregnant. And so there's some peace of mind, if you will, in going, okay, well, if I can get pregnant and I can have all those hormones raging through me and it doesn't change my survival, then maybe a little hormone is, you know, would be okay too. Now, I'm not, again, there's a lot of details into that. I'm not advocating for people to go out and start getting on hormones, but I think there's conversation that needs to take place. And quite frankly, if they're not estrogen progesterone receptor positive, I have started them on systemic hormones with a lot of understanding and a lot of conversation because they they just simply felt better on them and they wanted to get back to that. And so we had a very long conversation, eye opening. They knew what they were getting into. And because I know these studies on the not studies, but they followed the breast cancer survivors who got pregnant, it does make me think that you can at least have that conversation.
So that's a great place to end that particular topic. Any other things that come to mind that you say, hey, I think these are some points that women should know and understand, or areas that they should continue to investigate?
Yeah, so I think if I were going to just kind of have a shout out moment, I guess, be you want to be cautious as to who you connect with provider wise, because there's still providers that are living back in the WHI. And there are other providers that may not have quite the understanding of hormones that they need, but they're out there.
Pause on that. So, what is a question that will that a woman could ask to go, okay, I want to continue the conversation, or this is not the right individual for me. I'm just going to pause and then I'm going to look for somebody else. Is there something that will say, ding, 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 yes, I'll keep talking with them?
Let me go one more step, and then I'll come back to that. The other thing is that the menopause societies have to some degree failed us in that the WHI, they knee jerked afterwards. They're just now coming back around to going, well, wait a minute. Okay, so now we're doing some new studies, and they haven't said they're sorry yet. I keep waiting for that, um, but but they're beginning to come back around. But even though somebody is quote unquote, part of the menopause society, that still doesn't mean a lot of them want to stick traditional to kind of the black and white pharma. So to your question, what do you ask? You ask how long have they been doing hormones? What hormones do they prescribe? How long will they treat them? Because again, the myth is you have to stop after a certain period of time.
So if they say, if the physician or practitioner says that, you run. If they say, uh, you know, they'll use it on a select few, probably not your practitioner. What trying to pick up some.
Yeah, yeah. If they go, well, we'll treat you for 5 years and then we'll take you off them because we have to, or we treat you for 10 years and we have to take you off because we have to. Yeah, they don't have an understanding. So because there's zero data to suggest that taking hormones after more than 10 years. So people ask me all the time, how long can I be on hormones? I go for as long as you want the value.
There you go.
You know,
There's
if you're
there's 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 not an end date, just like there isn't an end date to your menopause.
right, exactly. And if you're hypertensive, you take hypertensive medicines, and if you stop them, what happens? Your hypertension goes out of control. If you are diabetic requiring insulin and you quit taking your insulin, your diabetes goes out of control. And if you are on hormones and you stop your hormones, your menopause is going to go out of control, right? I mean, it's the same thing. And so you stay on for as long as you want that value. And so you
So if they
need
give a timeline, not your physician.
no. And if they're uh the number of things they're willing to utilize for you is about this big, I would be a little concerned about that because you want to
Meaning
widen.
what? Meaning what? Because you, I mean,
Well,
you use the troches, you have the cream, you have a compounding pharmacy, right? You have all these different.
and I also do commercial. To be fair, I also do commercial. So, but you want somebody who's gonna has the full, they have every trick in their bag, or access to trick in their bag. Now, I don't personally do pellets, but I know people that do pellets, and I'm not opposed to it. I will send people to do pellets if that's what they want. The goal is that you treat the patient, and so you want every trick in your bag. And so if people's bags are limited as to what they're willing to offer, that's a little bit of a concern.
Sure, we're
And
gonna try to
and
fit
then
you in either A, B, or C. That's it.
yeah,
And
yeah,
if you
yeah.
don't fall into one of those, then I'm sorry.
Yeah, you wanna walk in and know that you're a person, not somebody who fits into a box, right? Um, so you're a person, you're an individual, you deserve a individualized treatment option. And then you wanna know how they're gonna follow your hormones, right? So you wanna know, are they gonna do if you're gonna go on bioidenticals or you're gonna go on pellets, are you going to have blood drawn? Are you gonna have saliva testing? Are you gonna have some sort of testing and follow-up? Or is it just kind of a shot in the dark and that's what you get? And so that's another cue. If you're going on any kind of hormone, is there some identified follow-up of is this working, is this not working? Right? And then getting to the broader menopause, you want to have somebody who's they may not order it. They may want somebody else to order if you're seeing a specialist for hormones, they may want your PCP to order your mammogram and your bone density, but you want to make sure that whoever you're talking to is interested in those things, right? And so those I think are the big keys. And then do they know how to evaluate and correct problems, right? So if you're a woman and you've got a uterus and you come in with postmenopausal spotting, does that person either know what to do him or herself, or do they recognize a potential problem to send you somewhere, right? And so those are the things that you kind of want to really think through. But I think if you get through those things, um, you know, you're probably going to be heading in the right direction if you find somebody that has a big bag of tricks to offer, a big understanding of how to take care of you, what the goals of treatment are, and do they know how to correct issues as they come. I mean, that's going to give you a pretty good guidance as to you know, whether you're headed in the right direction with that particular provider or not.
Yeah, I think if you can figure that out uh, up front, I think it'll save both parties a lot of time.
Yeah, and then the other thing too is you're not signing a lifelong contract. So if you are, with somebody for 3 to 6 months and you just don't feel like you're getting anywhere, then have that conversation with that provider. And if you don't get the answers you want, then you need to find somebody else. I wouldn't necessarily give up on that person, but you need to feel comfortable having a conversation with them. I'm just not getting what I need here.
Right. And it could be your gynecologist who's fantastic, except in that one particular area. There's definitely a lot of specialty clinics that exist that will focus on that.
And it could be the lady's body. I mean, a lot of times we don't, it takes a while sometimes to get them balanced. And it's not that we're not, the body's not responding. So you got to do a little more intervention. And as long as, again, as long as you're willing to have that conversation, I think those are the important things.
Yeah. And so what do you tell your ladies the average, right? There's some that'll get it right away, and then there's some that take a lot longer. What's the average to get some of these ladies to a balanced state?
Yeah, it's kind of hard to say because a lot of women feel great at 6 to 8 weeks and you never have to do anything. And then there's others that could take up to 6 months. And then it's like, oh man, but and there's always other reasons why people may not be absorbing, right? So there's another hormone. I was talking to a lady and she had tried to see, she comes from a far away, so she was trying to see somebody closer to where she lived. It's several states away, and she and I wanted her to get a DHEA level, which is a hormone that's needed to help with the biosynthesis of these other hormones. And whoever she was talking to didn't know what DHEA was, so she said, "Okay, never mind. I'll just keep going to Tennessee." Uh, but uh, but there, and then there's the thyroid issues. If your thyroid's low, you're going to have trouble absorbing. So there's a lot of things that go into this. That sometimes you have to look a little deeper. Sometimes we add a lot of DHEA supplements to people who are low in DHEA. There can be reasons why women don't absorb that you can identify and fix, but sometimes that takes a bit.
Understandable. That's a great point. Well, I think that's a great spot to end, and the fact that more women hopefully will be knowledgeable about the space, and certainly love to get the comments down below. And if you thought that this was beneficial, make sure you like and subscribe, and of course, share it with someone that you think could benefit. Dr. Jarnagin, amazing as always having you on the program. Until next time.
All right. Thank you.
All right. Have a great night.